Thank you very much, Dr. Yasser, for this nice introduction, and my great thanks to Menoufia Club, especially Dr. Safa and her team, for giving me this privilege and chance to be with you tonight. It's my honor and pleasure to be with a group of critical care and anesthesia. Hopefully, you see my slides, Dr. Yasser, and you hear me well.
Yeah. Okay, go ahead. Yeah.
Uh, My job tonight will be to try to convince people who are not yet convinced of use of critical care ultrasonography in the ICU practice. And we did a small survey, and the participant on this survey was a little bit small with Dr. Safa. We distributed the survey through Google form. We're aiming to see how interested is people in critical care ultrasonography. The responder to the Google form survey was around 23%. Though it's a small, but maybe reflecting that there is a great interest in critical care ultrasound, and majority of the surveyed people, they mandate the use of critical care ultrasound in the practice of intensive care medicine. Actually, there are different names of critical care ultrasonography as a sub-sign or subtitle of science of intensive care. There are different names. Some people, they call it critical care ultrasonography. Some people, they call it point of care ultrasound. But whatever the name is, the use of critical care ultrasound is targeting to answer certain questions in a very short period of time, trying to tailor the management of critically ill patients. So you have in mind a focused question, and you're gonna do a goal-directed exam to answer this specific questions in the shortest possible of time, because as we know, the ICU physicians are very busy and their time is not that too much dealing with different patients and always in a busy environment. So we have to specify here that we are not radiologists, we are not cardiologists, but we used to be the area in between the different specialties, dealing with people who are about to die. And then we are using all modalities, possible modalities, that other specialties using them in more details. For example, we use the ECG while the cardiologists are using the ECG. We see and interpret chest X-ray while the radiologists are the father of this. We have to know basic of CTs of abdomen, chest, brain, and we have to. And then also, it's very solid and well known that critical care, the ultrasound as a subset in the critical care, has different sub-modalities or tools that helps too much in diagnosing and directing the management of critical care. In general, there are two schools of doing the critical care ultrasound in ICU. School that they use it as I mentioned, focused, goal-directed. So they have question about, for example, is there pneumothorax on this chest X-ray? They do a specific exam to answer this question. Or they have a question of fluid. Should I give fluid, or I give vasopressor, or I give inotrope for this hypotensive shock patient or not? So they do specific goal-directed exam to answer this question in a very simple way. And then there are another school that I'm toward this school, which is routine practicing of critical care ultrasound for everyone admitted to ICU. We have to do the exam, and we have to be again focused, goal-directed, but routinely. So every patient admitted to ICU is a matter of discovering by critical care ultrasound to have something which was not even in your mind when this patient presented to you. So you do a routine exam whenever possible, time is there. You manage to get the exam with echo, with the chest, with abdomen, routinely. And then probably you find positive finding that was not expected, or you did not, you expected something and you see it, you prove it. So you have a patient who present to you with fever, shock, looks septic shock, but then you are expecting that this is not a straightforward septic shock, but rather with a cardiogenic element, that the inotropicity is defective. And you see with this, with your eyes, that the heart doesn't contract well. Also, you might have a negative routine exam. This negative might be expected because I expect that this is a straightforward septic shock. So what I'm expecting here is nothing more than what I see in the history and clinical and laboratory finding. So septic shock, very straightforward. A negative test with echo, for example. But sometimes you see a negative which was not expected to be negative. So I have a patient who I'm expecting him to be in cardiogenic shock, but then I discovered that this heart doesn't consist with cardiogenic shock, but rather with a septic shock, and so on. There are a lot of examples in this. And evidence, ladies and gentlemen, is very widely distributed nowadays, directing the attention to that the use of point of care ultrasound in intensive care patients help too much in identifying the appropriate diagnosis and choosing the right way to intervene in these patients. A lot of evidence on this. One of them is what you see here, a multi-center study, which was a prospective observational study, included a lot of patients, and the diagnosis was held in 87% of cases. And there was a modification of treatment in around maybe 70% of cases. The direction of management was changed by using the critical care ultrasonography. The impact of critical care ultrasound on management of critically ill patient is undoubtful. There are a lot of evidence indicating that probably a time is coming to mandate in every critically ill patients, not only the hemodynamically unstable patients, but all patients admitted to ICU has to have, as a part of their routine investigation, a critical care ultrasonography. What do we mean by critical care ultrasound? Is a critical care echocardiography, which can be basic or advanced level, which includes the transthoracic echo and transesophageal echo, but also the general critical care ultrasonography, which entails lung ultrasound, abdomen, vascular, neurocritical, and other modalities of ultrasound. Again, I have to focus here that what we are doing is a focused, goal-directed exam to answer certain questions in mind pertaining to certain situations to help in reaching the diagnosis and to guide the management. There are a lot of international statements and consensus about the training and mandatory training of ultrasonography in general in the literature from different societies, like American Society of the Critical Care, European Society of Intensive Care, and there are different levels of training that every ICU, a small or big ICU, has to have this different level of experience in critical care ultrasonography. They say that the basic knowledge has to be among everyone. Working in ICU has to have certain basic knowledge of critical care ultrasonography. Part of this ICU people, suppose that we have 10 persons in this ICU, 10 physicians, all of them, they have to have the basic knowledge. maybe 3 of them, 4 of them has to be having advanced level, 1 or 2 in every unit has to have the expert level as much as possible. And this is also was tested by different societies and recommended strongly by strong guidelines from strong societies, like what we just finished with the European Society of Intensive Care Task Force of Critical Care Ultrasonography, which I was honored to be part of it. And we just published the consensus of what does it mean basic critical care ultrasonography in heart echo, in lung ultrasound, in abdomen ultrasound, in neurocritical care, and in vascular, and in general, like the airway and many other things. We defined clearly what does it mean basic knowledge that everyone working, again, I'm insisting on this statement, that everyone has to be aware of. That's why I'm directing the attention of my colleagues here just to go and read in details this paper, which we just published a few months back. It's not surprising that even with this big evidence that we have everywhere, even in the developed countries, like in Europe, they are not yet well formulating programs of training and not yet formulating a very clear curriculum for the trainees in intensive care. This is very unfortunate. So in this survey, which was done by our friend Adrian Wong and many others, that they found that only 5 centers in Europe, they have accredited critical care echo program. And only 3 countries, they have critical care ultrasonography in general accredited programs. So it's not surprising for us when we did a survey in Saudi Arabia here to find no single curriculum accredited by the local bodies of the health societies in the maybe in the whole Gulf region. I'm not aware also if Egypt has one of them. Not surprising, but we have to work all together. First, the interested people, they have to work and do their. So you can find a lot of evidence supporting that the critical care echocardiography and in general critical care ultrasound is mandated in many indications in critically ill, hemodynamically unstable, any patient with respiratory or cardiovascular failure, any patient who's admitted with a chest disease has to have a basic critical care echo exam and lung exam or abdominal exam according to the clinical scenario and clinical situations. And you can see in this very nicely written narrative review by a group of European experts and led by our friend Dr. Antoine Baron. You find on this narrative view how they mandated that every ICU has to have their own structured training and they have their own machine capable of doing the necessary exams for the critically ill patients. There are a lot of methods around the use of critical care echocardiography, in particular in ICU. And people, they're saying, why I have to be bothered if I'm intensivist? Why I have to be bothered of seeing the heart by echo, which is a job of cardiologist? And then how can I answer questions related to the heart while I'm not cardiologist? And then they also, one of the false beliefs that we have to do a comprehensive study, full detailed examinations. This all are methods, not right. It's a false beliefs. As Paul Mayo and group of his researcher identified these methods in a nice way and a nice review published recently. And one of them is that why I should bother of critical care echo if I have other modalities which can help me, invasive or semi-invasive. Why I go with IVC by echo if I can read the central venous pressure by central venous line? Why I have to be bothered by pressure, pulse pressure variation or stroke volume variation using the echo, which is non-invasive, while I have Swan-Ganz, or I have a pulsion technology, a thermodilution technology, whatever is semi-invasive or invasive technologies. There are a lot of methods that critical care echo might not be equal to all of these invasives, which gives you numbers. So Swan-Ganz will tell you that the systolic pressure of the right ventricle is this or that, and the pulmonary pressure is this or that, and cardiac output is this or that, but it doesn't give you the anatomy. It doesn't give you the physiology under your eye. You can see with your eyes when you use the critical care echo and lung ultrasound, the disease, the normal anatomy and abnormality affecting the normal anatomy with your eyes, as I'm gonna show you in these cases from our real life. And let's start the journey now with some of the cases that you might face daily in ICU. How many times you round in your unit and the nurses are telling you in the morning during the round that this patient stopped to put any urine since a couple of hours while this patient is stable, young, RTA, like our patient, ready to extubate, hemodynamically stable, afebrile, all labs are fine, including the kidney function. What the nurse discovered that this patient is not putting urine for the last 2 hours. And what the fellows are doing usually blindly is to order, when they have oligouric patient, they order to give fluid blindly, regardless of this patient are indicated to be given fluid or not, underestimating the danger of giving a fluid unnecessarily for critically ill patients. And this is also a mass practice all over the world. If you look at this pragmatic, very nice, well-designed study called the FENIS trial or study, published several years back, the intensivists in different European countries were asked when you consider to give fluid, for example, what are the indications to give fluid in your patients? When they are hypotensive, when you're trying to wean the vasopressors, one of them is if they are oligouric. Majority of the surveyed intensivists in Europe, they said once the patient is hypotensive, we give fluid. And some of them, which is in around 18%, once the patient is oligouric, they give fluid. And when they ask about the objective criteria they rely on, like what parameter you rely on to give IV fluid to your patients, do you rely on CVP? Do you rely on pulmonary capillary wedge pressure? Do you rely on pulse pressure variation or stroke volume variation or combination of them? Majority again, they relied on central venous pressure in Europe. And minority actually, 9%, 2% only, they relied on echo parameters to give fluid. Look at this. It's very surprising for everybody in the field of critical care, echocardiography and field of critical care ultrasonography, to find that in Europe, which is most of them, they are developed countries, they are using still central venous pressure to guide their management. If we go back to this patient who is oligouric for 2 hours while everything is stable, if you just go and give a quick look to the heart and the main pipe, you're gonna see and find that the IVC, as you saw here, this is the IVC and this is the right atrium, a tube going to the right atrium. For those who don't have a lot of experience, this can be well trained in and well acquired with no difficulty. This is the liver and you are in the subcostal area with echo probe. You see the structure just near to the liver is right ventricle, and the one away from the right ventricle is the left ventricle. And then when you turn your probe, you see a tube or pipe opening into the right atrium, which is the IVC. If you see the IVC in ventilated patient doesn't collapse at all, this is indicator that the tank is full and this patient doesn't need actually any further IV fluid. If you look at the kidney as we've done here, you're going to see that the kidney showing with color a good perfusion. And if you measure the pulsatility index in the kidney, indicating how much perfusion, what is the strong indicator of the perfusion of this kidney, is it receiving good amount of blood or not, indicating that the pump is okay and hemodynamics are satisfactory. If the number is less than 0.5 pulsatility index, you have a good perfusion. And then if you extend your exam to the lower abdomen, you see here that the bladder is full. And actually, you're gonna see this is the Foley's catheter, and you're gonna see a stuff inside the urinary bladder, probably obstructing the Foley's catheter. And the solution here is not to give fluid, but rather to flush the Foley's catheter, and then the patient passed around 600 ml of urine. The solution for a big problem is very easy when you utilize the critical care ultrasonography. The matter is to look at the bladder and the Foley's catheter. In another patient, the scenario might be a little bit different. Another old age patient admitted with COVID, and he is known to have chronic liver disease, ischemic heart disease, and he is oliguric and unresponsive to repeated boluses of IV fluid. Look at the abdomen, you're gonna see that the liver is flooded inside a big bowl of fluid, and the kidney is surrounded with a huge amount of fluid, indicating that this abdomen is intra-abdominal pressure is increased, causing compartment. And the solution here is not to give further fluid, because if you look at the heart of this patient, you're gonna see that the circulation, the central circulation is full. As you see here, the left ventricle is full, the right ventricle is good sized, and the contractility is bad actually. And the reason why, because this patient is full of fluid and cannot tolerate more fluid. Not only that, but also you see with a simple maneuver, how is the left ventricle filling pressure? Parameters here showing that the left atrial filling pressure is high. How you measure the left filling pressure is easy to learn and easy to detect in a short period of time. The matter is, ladies and gentlemen, that do not see what I'm saying now as if I'm coming from a different world, or I'm making your job very difficult of learning something difficult to learn. We all started, and everybody in the field started like doesn't know anything. With insistence and with persistence, you would know, and you have no choice actually. It's not luxurious to learn this. If you are frontline intensivist dealing with critically ill patients, one of the tools that you have to master to acquire basic knowledge in is to use how to use the critical care ultrasonography. It's not less important than what you learn it, how to insert and to utilize the central venous pressure, how to intubate, how to go with a difficult airway, how to manage a ventilator crisis, how to nutrition your patient, how to assess the nutritional status, how to choose and what to choose in antibiotic-wise, how to manage using the critical care ultrasonography is mandated and not luxurious anymore. A lot of courses are there, a lot of materials are there. How to use or how to practice is easy to learn and not difficult at all. There are a lot of questions, but one of the common questions in daily round in our patients is to give fluid or not to give fluid. Sometimes it's a very straightforward to see the IVC very small and collapsing as you see here, or very big and doesn't collapse at all as you see here. This is consistent with the history of vomiting, diarrhea, or blood loss, or whatever it is. Hypovolemic patient, you go and give fluid. Here is a very supportive to stop or not to give further IV fluid because the tank is full. Regarding to the heart, signs are very clear. When you see the left ventricle, as you see here, very collapsing and kissing walls, like what you see in the long axis and short axis, and in the apical four, you can see that these ventricles are hyperdynamic empty needs more fluid. There is no doubt that you can train, and adapt your eyes to the abnormalities very easily, because others did the same way and got learned very easily. So there is no excuse again for anyone who is lacking behind to start the journey of critical care ultrasonography to go ahead and start, because you have to know when to give fluid. And the more important is when to stop giving IV fluid to your patients, and continuing giving a fluid to your patient at this point is detrimental. Is gonna kill your patient. When you see RV dilation like here, this is the RV, size is bigger than the LV, which is supposed to be normally less than the half of the LV. When I see paradoxical septal motion toward the left ventricle from the right ventricle, paradoxically from the normal physiology, then I know that the RV is under stress. And this stress is due to not only pressure, but also due to volume. This RV is full of volume. Why you attempt to give more volume? When you give more volume, you're gonna ask the right ventricle to sleep more or to dysfunction more, and the cardiac output will reduce. And ladies and gentlemen, you have to know and remind yourself that the cardiac output of the left ventricle equal the cardiac output of the right ventricle. To have a normal right ventricle, you have to have normal left ventricle, and vice versa. If you jeopardize the right ventricle, you jeopardize the left ventricle, and then you're gonna end by mortality, as I'm gonna show you later on several presentations and several studies. It's well known in the literature that only 50% of our patients, they are responding to the boluses of IV fluid, i.e. 50% of our critically ill patients, even if they deemed needing fluid, they are unresponsive to your fluid boluses. And you end by, as the evidence is showing clearly, that you increase the fluid balance. Every day in our round, we ask about the fluid balance. And believe me, those who are unnecessarily positive balanced every day, having a bad outcome compared to the less positive balances. Evidence is everywhere there. And one of the drawbacks that we are taking against the consensus or the sepsis campaign guidelines that published every year, that they're asking people to give empirically, blindly, bolus of IV fluid that reach up to 30 ml per kg, even if there is no indication to give IV fluid. Not every septic patient needs fluid. Keep this in mind. And that's why after more than pressures from everywhere on the sepsis campaign, the latest one, which was published recently, is indicating that echocardiography is mandated at any given time after early stabilization. Because you know how to stop and when to stop giving IV fluid unnecessarily. You have to know in septic patients what to give to support the hemodynamics, vasopressors or inotropes or both, because not every septic patient is hyperdynamic and they need vasopressors. Some of them, up to 50% of septic patients, they having septic cardiomyopathy and they need inotropes rather. We have to know when to give IV fluid. We have to fill, but not to overfill the tank. And we have to know when to stop giving the IV fluid. Not only that, but you have to know when to withdraw fluid from a hemodynamically unstable patient, when to connect the shocked patients to the CRRT machine, and you remove the burden of the fluid from the right ventricle, because this will improve the cardiac output of the RV and subsequently the cardiac output of the left ventricle. A young female who is admitted to us with a history showing that she had a Klebsiella ESBL in UTI, and she was primigravida at 20 weeks pregnant. Everyone was treating her as a severe UTI. She started to be tachypneic, tachycardic, desaturating, referred to ICU in RRT call. We went there, we saw her, we be assured that the right ventricle is fine, left ventricle is full, and the heart is actually hyperdynamic. We went through the systematic assessment because in every desaturating patient, 2 organs has to be assessed quickly. The cardiovascular system, particularly the heart, the center station of the cardiovascular system, which is the heart, and the lung, of course, because the most common reason for respiratory failure is cardiovascular failure. And the most common reason for the cardiovascular failure is respiratory failure. We have to remember this as a fact. Then we have evidence from different modalities here by echo, by eyeballing, and by assessment by numbers that the cardiovascular system of this lady is fine. She started to be hypotensive, but she was given liberal fluid in the floor, and here is her IVC. You can see this is a pipe coming, taking almost 80% of the venous return to the central right side of the heart, which is dilated and doesn't collapse, though this lady was tachypnic and with some labored breath, indicating that her intra-abdominal pressure with accessory muscle overwork can suck more the IVC. Rather, it's dilated. So it indicates that the circulation is full, and this lady, if she continued to deteriorate her hemodynamics, we should not attempt to give fluid. Because as you see here, the lung is over-congested. And there are a lot of issues bilaterally. You wouldn't know if this is effusion, collapse, or consolidation. This is interstitial lung edema, or whatever it is. The chest X-ray can tell you, cannot tell you details. If this is pulmonary edema, cardiogenic, non-cardiogenic, is this bilateral significant pleural effusion? Is there a consolidation or collapse? But the lung ultrasound can tell you much, can tell you even everything you wish to know. You question here if this lung is wet. There is extravascular lung water here or not. And as you see here, the pleura, the rib shadow, the pleura and rib shadow here, and a vertical multiple lines indicating interstitial lung edema. This interstitial lung edema is associated with corrugated, doesn't look healthy, pleural line. A criteria that everybody in the literature saying typical for ERDS. Not only that, but also, as we know, that the ERDS is characterized by non-homogeneously distributed pathology. So you see areas of the lung which looks totally healthy, and areas of the lung which is totally diseased. Look at this one. Though there are a lot of B lines, but the pleura doesn't look like badly injured. Not only that, but also when you go to the basis of the lung, you see clearly consolidation here. Look, this is the left side, and this is the spleen, diaphragm, and hypoechoic shadow above the diaphragm, which is fluid, pleural effusion, and the lung is turned to be tissue, like the spleen tissue. Lung became a tissue, means hepatonized lung. So this lung is consolidated. And we have signs to differentiate between consolidation and collapse. Details which I don't think the time will allow us to do, but it's clearly that dots here, white, that disappear, and some white dots does not disappear when we focused on this segment of the lung. Consolidated lung with areas of a static air bronchogram that does not disappear with inhalation, indicating that there is not only consolidation, but also collapse. So we know that there is consolidation, collapse, pulmonary edema, which is non-cardiogenic, and pleural effusion on this lady, details which cannot be picked up by just simple X-ray. Ladies and gentlemen, as I mentioned, POCUS, or point of care ultrasonography in critically ill patients, improved the diagnosis undoubtedly, and allows you to reach the final diagnosis very easily and earlier than the other modalities, and is associated with earlier time to intervene, the particular appropriate intervention. And also, this was found to be associated with better outcome, as with this recent literature just published few months ago as observational large study. There's no doubt that the chest radiography is totally inferior. chest X-ray is totally inferior to the lung ultrasound in diagnosing pneumonia. How many times we see cases of clear lung on the chest X-ray with a lot of pathology when we do CT or when we do lung ultrasonography. Another case of pleural effusion, very significant. This is the left side as I indicated here, spleen, diaphragm, pleural effusion, very big pool of fluid above the diaphragm. And the heart here is beating. The lung here is very collapsed. And we inserted under ultrasound guidance the pigtail to drain this fluid. The story is not here, but we drained almost 3 liters of fluid. But there are still a lot of stuff inside the pleural space. If you do the chest X-ray follow-up, you're going to see that there is a residual fluid. But how you know that this pigtail will drain the rest of this pleural fluid or not? You will never know. Even if you do CT chest, you have to do lung ultrasound to see live how is the behavior of this pleural effusion. Look here when we focus, this is the spleen, diaphragm, this is the pleural effusion. See when we focused on the pleural effusion with zooming, that we see strips of adhesions, a lot of adhesions and fluid, adhesions and fluid. This is very complicated pleural fluid emphysema or organized hematoma that will never be drained by simple maneuvers. And here you have to go with a thoracic surgeon consultation, and you go ahead and give local thrombolysis. And this is what we did, drain totally. And what you see here is the lung is inflated. This is the spleen, and the lung is here. And once the lung is becoming normal, you will not see a structure because the aerated lung cannot be seen by the lung ultrasound, but we see some white dots here, which are trapped air, indicating some collapse, residual collapse on the left side of the lung. It's mandatory, ladies and gentlemen. Lung ultrasound here would not be missed to become a very vital tool to reach the diagnosis and to try to help your patients. Evidence is showing that lung ultrasound is much superior to the chest X-ray. Equal, hear this very well. It's equal, not inferior to the CT of the chest, which is still in all guidelines, the gold standard. The CT chest is the gold standard. But I'm sure, and everybody in the field is sure, that a day is coming to be the lung ultrasound equal to CT in indicating different pathologies of critically ill patients, especially when you are unable to move your patient to CT when they are hemodynamically stable or very hypoxic on high setting on mechanical ventilator. We're about to publish and already published 2 recent small trials in my hospital comparing the CT chest to the lung ultrasound and chest X-ray. And also we did a quality project indicating if we are able to use lung ultrasound and to avoid totally using the chest X-ray in our unit, and we succeeded to reach a very good outcome. Acute respiratory distress syndrome definition Berlin-wise indicated, this is 2013, that you have to have bilateral opacities on a radiology tool, which was specific on the footnote here that to be chest X-ray or CT. They did not mention that this has to be or can be lung ultrasonography. Studies show that the lung ultrasound in ERDS is more sensitive and more specific than the chest X-ray, equal to CT. Let me give you an example here. This gentleman, young, presented with septic shock, and this is his X-ray on presentation. Would you imagine that this X-ray, which looks normal for everybody working in ICU field, is indicative of the lung ultrasound at the same moment, full of fluid in the interstitium, as you see here, extensive B lines, full of significant amount of turbid pleural effusion, and very significant consolidation and collapse. So it's lacking. That's why the Kigali modification of ERDS definition has stated clearly that the modality of chest imaging can be replaced using the lung ultrasonography over the chest X-ray and CT. I can give you another example of hypoxic COVID patient who was a bit more toward stable and became all of a sudden hypoxic. And everybody was wondering if this left side of the chest has pneumothorax or not. Look at the chest X-ray. You see some area here very obsessive and very suspicious of a front significant, maybe pneumothorax encircling the left side of the chest with some hidden signs of mechanically ventilated patients that you see V-shaped here between the heart and costophrenic angle. And you see some air encroaching over the diaphragm, and the sulcus is not very clearly identified, but maybe look very little bit deep. So signs of hidden signs of pneumothorax on ventilator. Would you go and insert intercostal tube for this patient who is ventilated? Or would you go and test the left side if there are signs of pneumothorax by lung ultrasonography? There are two signs. When you see them, it's a totally 100% against the presence of pneumothorax. And what you need to do is only to go and pick up the vascular probe, and you go to the mid-clavicular line, second intercostal space, where the air likes to be up. And then if you see, as you see here, in between two rib shadows, this is the rib shadow and this is another rib shadow, and this is the intercostal space, and then you see hyperechoic line here. If you see that this line moves with inhalation back and forth, we call this a sliding pleural line. This is number one sign, and the other sign is vertical lines you see that indicates B lines. These two signs, when are combined, are 100% against pneumothorax. And if you want to have another sign of no pneumothorax, you fire the M mode on the middle of this pleural line. You see the seashore sign, skin subcutaneous, and this is the pleura. And the area of the lung, which is down to the pleura, has to appear as a sandy area and not as a barcode above the pleural line. When you don't see barcode, this is totally against pneumothorax. So you are sure here that this patient doesn't have pneumothorax. And the question has to be pulled out of your mind in putting the differential diagnosis of why this patient is hypoxic now. Some of the intensivists, they rush to do CTs. Even, and as we know, all of our COVID are on high settings. And some of them, they have cardiac arrest on the suite of the CT because they are moved on less PEEP and they are moved on less FiO2, and you endanger their life. While you can answer the question very clearly, yes or no, with a simple maneuver that you can learn. Not only that, but also, as I mentioned, one of the common reasons for hypoxia is cardiovascular issues. You are assured here with the simple maneuvers that this patient cardiovascular system is also intact. So you have to focus on something else on this COVID patients, and critical care ultrasonography can help you to pick up if your patient is on pulmonary embolism, deterioration of his or her pulmonary fibrosis, the mechanics of the lung is becoming worsening, and you rule out serious life-threatening conditions very easily in a matter of no time. In between the heart and lung in ERDS, it's a very mandatory, very essential, before you increase the PEEP blindly, and this is practiced everywhere. Once we have ARDS patients that don't respond, we increase the PEEP without looking at the right ventricle. And this is a fatal mistake because the PEEP and hypoxia and the permissive hyperventilation and the permissive acidosis or the acquired acidosis all badly impact on the right ventricle. They cause RV failure. And if your patient is RV is suffered because of PEEP, they might die because of RV dysfunction. And the solution here is not to go higher with the PEEP, but you find another way to save the oxygenation, to save the lung, and also to save the right ventricle. And the bronch might be the solution. The message here is, if you're increasing the PEEP in your patient, don't do this blindly, but you have to have evidence that the RV can tolerate this increase of PEEP. Otherwise, you cause a detrimental bad effect on the right ventricle. And that's why the consensus from different studies is mandating that every ERDS patient has to have echo examination and to be sure that the right ventricle is not suffering for every ERDS on high setting before you judge to go higher with the setting. Mechanical ventilation weaning is a daily question, and sometimes it's a very distressing and very worrisome to take a lot of time in critically ill patients. We have a lot of failure. And this failure of weaning, most of it is because we wean blindly. The diaphragm, ladies and gentlemen, has to be seen before you wean. You have to see the diaphragm, and take it from me now and from many others in the field, that the great advantage of critical care ultrasonography is that you see with your eyes what you're looking to assess. If you look to assess the heart, you see the heart, you don't take numbers. When you assess the diaphragm, which is taking care of 80% of the respiratory function of your patient, and if you have diaphragmatic dysfunction, your patient will eventually fail the trial of extubation. How you see the diaphragm is the only way to see the diaphragm is to do bedside, easy, non-invasive, safe test using the ultrasound machine. Vascular probe, you go to the anterior axillary line, just above or at the level of the nipple on the right side, you see part of the liver as you see here, and then you're gonna see a layer, 3 layers above the liver, which is diaphragm. And then you're gonna see with inhalation, with the liver moving down, you see if the diaphragm thickness increases or not. You can measure this. If you measure the thickness and you find the difference between inspiratory, which when the diaphragm increases in thickness, because diaphragm is muscle, skeletal muscle, when it contracts during the inspiration, its size will increase. When it's increasing in relative to the expiratory resting times thickness by more than 25%, your patient will tolerate the weaning process, will succeed the weaning process. Not only that, but also you can see if there are any stuff in the pleural space affecting the contraction of the diaphragm. As you see here clearly, if this is the liver, this is the diaphragm here, you see pleural effusion, but you see something anchoring, attaching to diaphragm, pulling the diaphragm oppositely, paradoxically, away from giving the free space for the diaphragm to contract. Would you expect this diaphragm to function well? And how you know that if you don't see with your eyes? Even if you do CT chest to assess the diaphragm, it's gonna tell you that there are effusion here. But what about the anchoring of the diaphragm? What about the adhesions that affecting the free movement of diaphragm? The free space that has to be there for the diaphragm to expand. This is crucial. This is very important. How you would expect somebody like this gentleman to succeed weaning from mechanical ventilator if their systolic and diastolic function are bad? And how would you know that the heart can tolerate the stressful condition of weaning? You have to assess pre, during, and after the spontaneous breathing trial, 3 things before you decide to go for extubation. It's not a matter of a spontaneous breathing trial or RSBI numbers or the tidal volume numbers on a pressure support, whatever is. All of these are fake and can be deceiving. You have to see the heart, lung, and diaphragm before you decide to take off your patient from mechanical ventilator. Vascular critical care ultrasonography is pivotal, having a pivotal role in critically ill patients. All of us inserting line in ICU. Some of us still are doing this maneuver blindly. And they go to insert, and they're very expert, by the way, inserting the central line in few seconds. And some of my colleagues are saying that I can blind and insert the line. I can look away and insert the line. But tell me, how can you identify that the internal jugular vein here is totally thrombosed? And attempting to insert a line in such a kind of cases is dangerous to core this thrombus and dislodge it maybe to the pulmonary circulation. How would you feel that the internal jugular is thrombosed? How many times, ladies and gentlemen, you attempt to insert a central line, and though you are feeling the carotid pulsation, you're going, as you learn from everywhere, lateral to this pulsation feeling, and you go with the needle, and you never satisfy to puncture the internal jugular vein. How many times? We found in our study, which we published several years back, that the normal anatomy we are expecting is missing in around 15% of cases. The internal jugular is not anatomically on the same area that you are expecting, which is lateral to the internal carotid artery. It might be above the artery. It might be even medial to the artery. It might be inferior to the artery. And this is very dangerous. Though the practice is highlighting very straightforwardly and very impressively that you have to use the ultrasound guidance in inserting any invasive lines to the neck, either internal jugular or subclavian or even the femoral area, even if you are very expert. And medical legally is not, you are not covered if you are not using the ultrasound guidance. Though we have still people who are not interested in this technology, who are resisting this technology. Even in Europe, look at this survey. 35% of European surveyed doctors in intensive care, they found ultrasound unnecessarily in inserting or guiding the insertion of central line. Imagine this, carbon monoxide poisoning patient who is in our unit, and we used to do routine, as I mentioned, I'm from the school of doing routine study. Internal jugular vein is there, but there is a thrombus on top of this central line which is inserted just yesterday. Just yesterday inserted central line, and then you found a thrombus attached to this line. Do you believe that a central line in internal jugular vein after 1 day can induce thrombosis? No, actually, we don't say that, but we know from the literature that the carbon monoxide increases the risk of thrombosis in the poison patients. The danger here is if you insert this line blindly, you dislodge the thrombus. Not only that, but also if you don't do routine, and nobody's expecting that this patient with 2 days in ICU, young, would have a thrombus in internal jugular. Look at it. It's a ball. It's moving very freely. It can be dislodged and go to the RV outlet anytime. Very dangerous. And here, another advantage that you know if the RV started to suffer or the pulmonary embolism is started to be there or not, if they are started to be hypoxic. When we reviewed the literature, we found that in carbon monoxide poisoning, the risk of thrombosis increases in the first 90 days by more than 20-fold increase comparing to the normal patients. Not 20-fold increase during the first 90 days. The risk increases by 20-fold. The neurocritical care ultrasonography is very promising in critically ill patient to monitor the ICP easily, non-invasively, easy to learn, bedside, non-invasive, no radiation, no intervention, no invasive intervention. And you would know how is the intracranial pressure of your patient. Optic nerve sheath diameter is easy to learn and easy to detect, easy to use. Transcranial Doppler is also found to be easy to learn, easy to pick, easy to study, and very conclusive very promising. We just published a few months ago a study comparing the optic nerve sheath diameter to invasive technology in detecting the increased intracranial pressure in traumatic brain injury. And we found that the sensitivity is very high compared to invasive technology. There are many other ways and applications in ICU patients using the critical care ultrasonography, in nutrition assessment, in airway management, in regional anesthesia, and many others. Courses are there everywhere. And there are a lot of people doing these activities every now and then. And you can find a lot of courses in the internet, free or charged or whatever it is. And we are happy to invite you for our activities, and you can reach me from the different areas. And I hope I didn't take too much time, Dr. Yasser, and this was just a highlight of a journey with a critical care ultrasound in the daily environment and activities and around in ICU, just examples of cases, just to open the mind and to open the window and shade lights on these important modalities that I'm sure some of you might be more expert than me, and we learn from each other. Thank you very much.
Thank you so much, Ashraf. Can you show me the previous slide, the courses organized by you? Yeah. Is it done or not yet?
It's all in the Saving Lives Academy, and we finished them. But Walid, thanks for Walid Al-Habashi and Saving Lives Academy, taking the recorded versions and putting it available online. Of course, it's for money. It's not free, but it can be with a lot of discount for people coming from Egypt.
Does he have any YouTube access for these lectures, or it should be paid?
Some of them are on the YouTube. Yeah, some of them are free on YouTube.
And you can teach these courses online?
Yeah, very happy to do.
Because I see a lot of comment. Everybody's very interested and very happy from your presentation, and myself, of course. So I think you should transfer your experience to the young generation as soon as possible, inshallah.
Happy, inshallah.
Okay. Waiting the questions. There is no questions yet, but I will have some comment for you. You have one of the articles that you mentioned, ultrasound from head to toe. It's written with many persons from the European Society of Intensive Care. I think my suggestion for you, if you have some lectures, we should invite you again to focus in organ by organ, as you mentioned, from head to toe. So ultrasound on head, then next time on the neck for the internal jugular veins or carotid or whatever, then lung, then step by step. You give a very nice collections from different diagnoses, different organs, but I need it more organized next time, inshallah. What do you think?
Yeah,
Are you ready?
This is what we actually thinking of, Dr. Yasser, now. Probably very soon, we're arranging with the Saving Lives Academy the 3rd annual conference of critical care ultrasonography, and after the conference, we'll have a hands-on 3 days. But actually, it's here in Jeddah. Most likely, will be in Jeddah. What I mean is, what you're thinking of is totally what we think of at the level of European Society of Intensive Care. And I'm very proud to be part of the task force of the society. And we are writing now a book as a reference for the critical care ultrasonography under the umbrella of the European Society. And also, we probably, I'm not sure if we succeed to do, we'll probably arrange the same way of course from head to toe, basic knowledge. So the one who attend this has to know what is needed from the basic heart, what is
Yes.
needed from the basic abdomen, lung, neuro, vascular, DVT, nutrition, airway, basic. Yeah, we are arranging something like this.
So you have a curriculum for that, for the beginners or for the junior residents or somebody want to teach curriculum.
Yeah, there is a curriculum written by the American Society, the Society of Critical Care Medicine, American one, Canadian, they have one, Australia and New Zealand, they have one. European Society was still working on this. Probably it will be there, but it's well known, Dr. Yasser, from different consensus. This is one of the problems, actually, that there is no uniform agreement among the big societies, and we are on the way to arrange something like agreement on this, so the whole world should speak the same language at the level of the junior trainees up to the level of expertise in ICU. But this is a dream.
Yeah, I understand.
Dr. Yasser, I have a question, Dr. Yasser. Please, I have a question.
Go ahead.
I have a question.
Go ahead.
Okay. Please, Dr. Ashraf, shall we have ultrasound will replace chest X-ray for critically ill patient, and it will have the prognostic and diagnostic value, especially in COVID-19 patient, please?
Thank you for the question, Dr. Safa. Very nice question. And actually, as I showed in some of the evidence, that the clear answer of this is not yet in ICU for medical legality. So, but for the practicality, the ultrasound, the lung ultrasound is more yielding in a sensitivity way and specificity way, far away better than the lung ultrasound. And how many times, by evidence, that the sensitivity, for example, for the chest X-ray for a pneumothorax diagnosis is only around 50%. So you might miss up to 50% of cases of pneumothorax if you rely on the lung on the chest X-ray. And the specificity doesn't reach 80%. So there are around 20% false positive chest X-ray. You see pneumothorax on the chest X-ray, but there is no pneumothorax. And several times we stop colleagues from inserting intercostal tube because the lung ultrasound is totally negative. When the people insist to go with the chest X-ray because it's positive for pneumothorax, we ask for CT, and CT comes the same like the lung ultrasound. Back to the question, can we, at a day, can we come to this stage that we get rid of a chest X-rays in ICU and rely on lung ultrasound? Yes, this day is coming. And actually what I did, and I'm publishing it, published the abstract in Intensive Care Journal, that when we went through the lung ultrasound only in ICU patients, and we stopped to do any chest X-rays for 6 months, and we found that there was no difference in outcome. We picked up things very earlier compared to when we did the chest X-ray. The cost was less, the safety on the staff and patients. You have to imagine that when you do chest X-ray every day, for somebody who's staying in ICU for 2 or 3 months, COVID patients, you're exposing them to rad every day, around 0.4 rads every day. Cumulatively, this might be toxic radiation dose, not only for the patient, but also for the staff. While you can drag the machine, you go bedside and you study the lung from the first area to the last area. With maybe 10 minutes, you get all answers that you need to answer. And back to the basic rule, which is focused, goal-directed exam. You have a question, and then you look to see if this question can be answered. Yes, no, or I don't know. Yes, there is no pneumothorax. Yes, there is pneumothorax, or I don't know. Something is very confusing. I have to go with CT chest, and so on.
Yes, sir. Dr. Ashraf, please, after your valuable and informative lecture now, I see chest X-ray as a solid and something which has no rule at all. And I will insist even for my colleagues and my residents to use ultrasound. Is so valuable after your valuable informative lecture. I have a second question, please, about the increased intracranial tension and the sheath of optic nerve. So it's impressing for me. This is for first time to hear that. Please, can you magnify some information about this issue, about the increased intracranial, especially in head trauma or traumatic brain injury or whatever, yeah.
Sure.
Thank you.
You know, back to one of the basic golden rules here, that before we jump to use anything, we have to go through the systematic way of learning how to do that. Because I'm afraid if we do something and we are not mastering it and we rely on, and then we do mistakes and we badly impact on the management. But again, learning critical care ultrasonography is very easy, by the way. Learnable and doable. You just need to attend some courses. You go through certain videos and see how the people do in the exams, and adapt your eye to what the normal looks like and what the abnormal looks like. You know what radiologists are doing during their training, or even up till their highest seniority level? They look at the books. When they are confused about certain diagnosis, they look at the books. How is this presenting on the pictures? So just learn, teach your brain how to see this abnormality, how you see the effusion. It's the same way in patient X like patient Z like patient Y. Effusion will appear as effusion in American patient, in Egyptian patient, in Ugandan patients, in any patient. Doesn't matter. So, and that's why the British people are saying a very nice statement, which is the brain, the eye see what the brain knows. So you have to know, then your eye will see. This is number one. Number two, the optic nerve sheath is surrounding the optic nerve. And the subarachnoid space of the optic nerve, which is in between the optic nerve itself and the sheath surrounding it, is in continuity with the CSF of the brain, the subarachnoid space of the brain. So whatever things will increase the pressure of the brain will expand the subarachnoid space, and then it goes down to the optic nerve, distending the sheath, so the diameter will increase. There is a certain level for this. If it's beyond this level, the specificity is more than 90%, that this indicates high ICP. If you put this, which is non-invasive, we do it bedside, and with several cases, we picked up, we directed patients to OR based on this. It has to, and this is another golden rule for any critical care ultrasound exam, that it has to fit into the clinical scenario. Don't be decided away from the history, examination, clinical presentation, and everything. It's one of the tools.
Yes.
It just can replace the CT, it can replace the chest X-ray, it can replace the Swan-Ganz, but again, it has to fit into the clinical scenario. Otherwise, you should not rely on something and you forget the others. That's it.
So, sir, you reply me now. I ask you about your how can you rely on diaphragmatic movement by ultrasound to take the decision to wean your patient?
Yeah, as I mentioned, it's one of the daily difficulties in ICU. And we see a lot of cases that fail extubation, though they appeared to be ready for extubation. And you're surprised why this patient is back to ventilator. The RSPI was fine. The FI2 was good. Patient was doing well on pressure support of 8/5. What is this? This is totally deceiving, because the pressure support is, at the end of the day, is a pressure support. It opened the circle of mechanical ventilator. The inspiratory valve will open, responding to this pressure. And then whatever negative pressure the patient does will initiate the cycle. And you might have a good tidal volume, by the way, but this doesn't mean that the things are ready. You have to see the diaphragm. You have to have evidence that this diaphragm can cope with the period after extubation. How you know this? There are two ways. One way is to measure the thickness fraction of the diaphragm while your patient is on a very minimal pressure support, or even better, to be disconnected from the ventilator, and you put the probe, the ultrasound vascular probe, at the anterior axillary line, at the nipple area, and then you see the diaphragm as I showed in the slide. You measure, you put the M mode, and you see during the inspiration how much the thickness, during the expiration how was the thickness. Expiration is the relaxing time. Inspiration is the contraction time. If the diaphragm increases in thickness by more than 25%, this indicates that this diaphragm is strong, and this patient will be successful to extubate from ventilator. Easy again to learn.
Thank you, Dr.
I'm afraid, wallahi, Dr. Safa, I'm afraid, I'm very sorry to my colleagues if I made it more distracting. Maybe you're gonna ask yourself now, what a lot of informations this night, what a lot of difficulties this night. How can I learn all of this? And this is totally bad message if I delivered that. No, everything can be learned. You start the journey, and within few months, you're gonna master it, because others did the same and they mastered it. Your patient is gonna benefit. Your patient is gonna benefit. ومن أحياها فكأنما أحيا الناس جميعا.
جميعا طبعا.
Yeah.
Dr. Ashraf, in spite of the many valuable and many highly informative information you delivered to us, but really delivered so simply, so elegantly, and so informatively. No one complained any difficulties with you. You are so elegant and highly informative lecturer, of course, Prof. Of course.
Thank you.
Yeah, just I want to ask you, Ashraf, from your experience, what about the learning curve of the young generation? They can accept the training quickly, or they take some time to be more experienced in ultrasound in general?
Very, very, very good question, Dr. Yasser. Thank you very much for this question. Actually, this was tested in the literature. You would imagine that it needs the trainee, even the medical student, to attend a didactic course, theory course of 5 hours or more, at least 5 hours, listening, and then practicing hands-on under supervision. Doing, for example, for the optic nerve sheath diameter measurement, which appeared for some people as if somebody's coming from the space talking about something. No, it took the supervised people to do 30 exams if they don't have any experience with ultrasound, 30 supervised exams. For those with experience with lung ultrasound, whatever the experience is, they know how to hold the probe, they know how to adjust the setting, the basic things. It took them 10 supervised exams. Not only that, but also, if you go for every part of the learning curve for every part of critical care ultrasound, for example, the lung ultrasound, respiratory therapists, which are not physicians, but they are very talented people. The respiratory therapists, when we taught them how to use the lung ultrasound, it took us, again, the tactic part, which is a theory part, few hours, and then hands-on on the course itself, and they were able to do it. This was tested and published in the literature. 2 days course, they were able to pick up the big finding. They would know how to diagnose offline or online, pneumothorax, effusion, consolidation, collapse, how to see the diaphragm, easy. Echo, the same. Abdomen, the same. It's just start. And by the way, this is something I'm not complimenting, but we noticed that we have talented people in Egypt. They are talented. Although we have a lot of colleagues from all over the world that I know some of them, they attended this presentation. But I noticed that we have a lot of talent. And that's why I'm very surprised when I saw the small quick survey that the only part of the critical care ultrasound that is in common use is the vascular line use only, but the echo is underutilized. We can start the journey, and the information is everywhere, Dr. Yasser. Everywhere.
I asked these questions because as in your presentation, a lot of decision making based on the ultrasound or echo finding. So I am imagining a young intensivist, maybe 2-3 years experience, and he's working at night, and some patient come for him, and he has reasonable experience in ultrasound. And for example, he want to insert internal jugular vein. As you mentioned, there is a thrombus in patient with carbon monoxide. So he may see or he can't see a thrombus in the internal jugular or another vein. So it is a decision making. That's why I asked how to increase the experience or to improve the experience of young generation, as you explained.
Yes.
The last may comment, not as you mentioned, you don't need from the ICU physician to be a cardiologist or radiologist to be professional in the use of ultrasound. But if you want to summarize, for example, patient coming in shock, you don't know which type of shock at the moment, and you want to use the ultrasound, can you tell us ABC what I can do for myself? The patient is hypotensive and it is not clear, it is cardiogenic, hypovolemic, there is no trauma, it is not a traumatic. So ABC approach for a patient with shock, not traumatic shock.
Very good question. And this is well settled in the literature, in the guidelines. One, you go with the view of intensivist, which is the subcostal view. You put the probe, you know how to put the probe in the subcostal area. And then you answer 4 questions. How about the IVC and right ventricle size? So you decide about fluid. Number 2 question is, so number 1 is the IVC and the fluid. Number 2 question in shock patient is, how is the RV? Is it big dilated? So there are signs of obstructive, probably pulmonary embolism. Number 3 question is, how is the left ventricle? Is it empty left ventricle, hyperdynamic left ventricle, septic? Or it's a dilated, not contracting well, cardiogenic. The 4th question, which is very critical and life-threatening, which is there pericardial effusion or not? So 4 questions can be answered with one view in 1 minute. You just put the probe, look at the right ventricle, look at the left ventricle, look at the IVC, and look to see if there is pericardial effusion or not. And if there is pericardial effusion, is there collapse of the right side, right atrium and right ventricle or not? So you know if this patient is tamponading, you know if this patient has cardiogenic shock, you know if this patient has a hyperdynamic heart, which is consistent with distributive shock, or no, it's a matter of something else, like anaphylactic, you see hyperdynamic, neurogenic, you see it hyperdynamic. So it's a matter of 4 questions, focused, goal-directed exam to answer certain questions in as shortest possible time with answer of yes or no or I don't know. And I don't know is a good answer because again, you should not plan a care on something you are not sure of.
Okay. Dr. Ashraf, you have any question from your side? You have questions for, no question. I see Dr. Ashraf is tired, huh? You want to drink water?
No. I'm very no.
But anyway, this is a special request from myself because of Dr. Ashraf. As you mentioned, you have from head to toe ultrasound approach. I need you, please, next time to present ultrasound for the head, either for neurological cases, either trauma or not trauma, to tell us approach and to benefit all. It is unpaid, huh? Not unpaid
Yeah,
course.
yeah,
Huh?
sure, sure. But you know, the best to teach, and he is my teacher on this. The best to teach the neurocritical care ultrasound is Walid Shibl.
I understand. Just to give us some, at least maybe 20-minute or 30-minute about introduction, about how
Sure,
to use and what is the indications, what
I
is you
would.
can,
I
okay?
would. But we can arrange it.
You promise, not your hope.
Yeah, yeah, I promise. But let me suggest, if you agree and Dr. Safa agree, to
It will be
invite
after
also.
Ramadan,
Yeah,
Dr. Ashraf, after
yes,
Ramadan.
yes,
Don't
and
worry.
also
And it will be symposium and very, very elegant today about head trauma, and it's a surprise. It will be a surprise, and we will arrange both three people
sure,
here.
sure,
Okay? Let
sure,
us to arrange. Okay?
sure.
Okay, I think it is enough for you. You look so tired. Sure, it is clear in your face. So we are very, very thank you for Dr. Ashraf, and I hope to see you very near in our meeting. And thank you for Dr. Safa, and Dr. is the one organizing, and end by Dr. Safa comment, please.
I'm so happy, and I am so a great honor to have you, Dr. Ashraf, today.